Okay, so my name is Dr. Alex Pavidapha. I'm an interventional radiologist. I work here in Northern Virginia. I did my medical school training at Ross University, but most of my training in Massachusetts, where I did early specialization into interventional radiology, which is the field that I now practice in. And while as a resident, I was selected as chief resident and elected some honor societies, and then did my subspecialty training as well in Massachusetts. I moved down here about 3 years ago to pursue this job opportunity um, here in Falls Church. So my partner, Dr. Chaudhry, she's actually a local. So she works with me in Falls Church. She got her medical degree from Georgetown University. She did an IRDR residency at MedStar Georgetown. And then she also served as chief resident. So for those of you who don't know, it's usually a distinction that is you're usually elected by your attendings or your superiors and then also your peers. So it's a pretty prestigious honor to get. And she also is very interested in women's health, venous disease, and quality improvement. She's a native of Washington, D.C., and we're excited to have her here as part of the team. So what is vascular interventional radiology, and why are we doing a talk here on knee osteoarthritis and knee pain? How does that fit? So interventional radiology is a subspecialty where you're basically utilizing imaging or image guidance to either diagnose or treat different areas in the body. So the concept of interventional radiology is basically we're always trying to innovate and do the least invasive techniques in order to minimize any type of risk or side effects to the patient to still have great outcomes. And that's exactly what we're going to be talking about today. So these procedures typically have less risk, less pain, less recovery time. Oftentimes, just as in this procedure, you come to the office, go home the same day. So no stay in the hospital, and oftentimes not done in the hospital at all. So knee osteoarthritis. So why is this important? And this is what we're talking about. So it's very prevalent across America. Over 30 million people in the United States are affected with osteoarthritis, with the most common joint to be affected is the knee joint. Hospitalizations. There's over 100,000 hospitalizations a year related to NSAID toxicity. So when you take these painkillers like Aleve, ibuprofen, Motrin, what have you, those can be really irritative and toxic to the gut or in your stomach. And oftentimes it can lead to bleeds or ulcers that can lead to hospitalizations. Worse than that, you can have deaths related to NSAIDs as well. And lastly, just to put this in the context of other treatments, and I have a slide right after this to kind of talk about some of the other treatments. Joint injections or knee injections are done incredibly commonly in the United States, over 4 million knee injections annually. This includes steroids and Synvisc. So what are the treatment options? So these are all different cartoons kind of depicting some different treatment options. So that cartoon there on the far left is essentially it's a nerve ablation. So this is not changing the structure of the knee or anything like that. But the idea here is that it's going to basically deaden those nerves that innervate or are in that area, so it helps relieve pain. The pictures in the second to the left is an image of someone going for a total knee, which if you ever see, whenever you see orthopedic surgeon, oftentimes they are pretty brawny people. It's because it does take a little bit of muscle to do some of this stuff. And then third to the left, you're going to have joint injection, which I'm sure many of you have already undergone. It's a great minimally invasive option, but it tends to have an effect up front where if you keep going and going for it, the effect kind of tapers down or tamps down, and it's as effective over time. And then this is just also a cartoon when they're replacing that knee there. Okay. So how does this even work, and what is an orthopedic embolization? So the idea is there's some type of trauma or injury to the knee. And what ends up happening is there's inflammation related to that injury or trauma to the knee. And the body basically, inflammation is increased blood flow there. So you can see swelling and you'll have acute pain, but this chronic pain actually happens in this setting where you're having these cytokines or these essential chemicals that your body produces go there, which induce says angiogenesis, or basically new small abnormal blood vessels to form in that area. And it's kind of like a cycle that's kind of feeding back on itself, where you have these new little blood vessels forming, where you have more of these cytokines and actually more inflammation. The body's actually trying to heal the area and bring more blood and nutrients to that area, but it actually perpetuates this pain cycle. And this has been investigated and studied by people a lot smarter than I am, who are doing bench research. And this is just a cartoon kind of illustrating all those things that I kind of tried to dumb down in that picture. But so what data and what research has been done, I'm not gonna dive too deep into the literature, but I just want you to know that there's a lot of literature out here supporting this genicular artery embolization as a treatment for knee pain secondary to osteoarthritis. This paper was published, and the lead authors in this are people in our group. Sandeep Bagla, who's the founder of the company that we work for and partner of ours, was the lead author. He's actually we're doing probably one of the largest studies ever done. It is the largest study ever done for GAE, comparing it against joint injections. He's the global principal investigator, and I'm one of the principal investigators. Rachel is also one of those principal investigators. But needless to say, that was kind of the initial research done, and it shows 100% of patients had significant decrease in WOMAC and VAS. Those are just scales that we used when we're doing research to try and quantify how much pain and functionality that they have improvement in. And that was shown to bear out even at 6 months, and 65% decrease in NSAID use at 6 months as well, which is important. So this is also more research. So there's been a sham study. This is the only really sham study that's been done in our field. These are numbers talking about these scales. It's probably a little bit much, but basically half the patients got a GAE and half of them didn't. The ones who got the GAE did very well. And then the ones who didn't get the GAE, once they crossed over to the side that got the GAE, they also did just as well. Just continuing on, this is all the different research that's been done. So who's a candidate for GAE? And that's probably one of the more important topics for this talk here. So patients, and there's not a one size fits all, but patients who failed physical therapy, those will be great candidates. Patients who've failed RF, so that was that ablation that I was talking about in the beginning, or injections. And by failed, it doesn't necessarily mean the injections didn't work at all. It's just that kind of what we talked about in the beginning, where the injections may have worked pretty well in the beginning, and then as time goes on, they work less and less and less and less. So those are great candidates. Patients with palpable pain, meaning if we come in and see you and do an exam on you, we can kind of press on the areas that you say typically have pain, and we can reproduce that pain, then those patients are typically really good candidates. Patients with synovitis, so that is, we talked about the synovium, or that lining of the joint. When there's inflammation there, we can sometimes even see that on ultrasound, or will be demonstrated with fluid accumulation in the knee, which we can also see on ultrasound. So that synovium is what we were talking about, that basically recruits that new blood flow or blood vessel. The synovium lines the joint. And essentially, it creates fluid to lubricate the joint, but it also resorbs fluid. And when you have that inflammation and that balance is out of whack, so you produce more fluid than you can absorb, and that's when you can get that swelling of the knee. So that's kind of what synovitis is. Hemarthrosis patients, so those are patients who actually have blood accumulating in that joint, which it can happen in relation to patients with bleeding disorders, or patients who've actually already undergone a knee replacement and there's bleeding related to that, or surgery or trauma. And this will also help with that. And then, by and large, patients with mild to moderate OA. Now, once it's severe osteoarthritis and it's completely worn down and bone on bone, it may not help as much, but that's why I have a slide probably coming up here where you'll see kind of what you can expect with some type of workup. So yeah, so workup. So preoperative imaging, typically there's an MRI done at some point. Not necessarily, doesn't necessarily have to be done, but it's usually to rule out or evaluate if there's any serious structural issues, like a severely torn meniscus where there's it's called like a bucket handle tear, or a severe cruciate ligament tear, or something that you wouldn't, or loose body, something that the pain could be attributed to and fixed in a different way. Like I mentioned on ultrasound, you could see thickening of that synovium or that lining of the joint, or synovitis, and effusion or fluid accumulation in that joint, and then potentially even hemarthrosis or blood in that joint. Routine labs would typically be done. We'll do a physical exam. Sometimes it's done on the day of the procedure, sometimes it's done before. But it's really to assess the site of maximal pain. And I'm going to show you pictures from what a procedure looks like. And really anyone looking at it can say, hey, this looks abnormal. And then we kind of get it to look more normal. And then obviously we're doing this in conjunction with the great docs at Anderson Clinic. So obviously we want people to see their orthopedic surgeons as well. So here's a cartoon kind of depicting what this exactly is. So these are the blood vessels in the leg here. And we typically go either from the top of the foot or the groin on the opposite side. So if we go the top of the foot, we'll go the same side as the pain. And if we go the groin, we'll go the opposite side. So we bring a small catheter down to the knee joint, and then we'll take pictures, find those abnormal blood vessels, and then slow down the blood flow in the abnormal ones while maintaining normal flow in the parent vessel. And we'll usually, here you just see it selecting one branch. There's typically 6 blood vessels that go in that area. We'll typically investigate all the blood vessels going in the region of pain and treat the ones that are abnormal. So what to expect on the day of the procedure. So after you've done your consult and we've assessed that you're a pretty candidate for the procedure, it's a day procedure. So it's done in our office in Falls Church. So you come there, go home the same day. Would have you change into a gown, would start an IV, and then we'll bring you into a procedure room where we'll administer what's called moderate sedation. So you'd be in a twilight sleep, nice and comfortable. You may not feel one tiny pinprick, whether we go at the top of the groin or the top of the leg or the top of the foot. You'll feel that little pinprick. After that, there's no pain associated with the procedure. We'll use that small catheter as that cartoon depicted there. Go to those blood vessels using live X-ray or fluoroscopy and contrast dye to use the blood vessels essentially as a highway to map everything out. Take those catheters to those abnormal blood vessels, take pictures to find those abnormal blood vessels, and then slow down the blood flow. When we're done, we take the catheter out, close the tiny hole that we made if we go from the top of the leg, or just hold pressure if we went from the top of the foot. And then you're in the recovery for 1 to 2 hours, depending on which way we access. Then you go home that same day. You can't drive yourself that day because of the sedation medication. Downtime is really just take it easy for a couple days. Some patients may feel some stiffness or pain for a couple of weeks, and we give a prescription for an NSAID or pain medication to help with those couple of days. Notice improvement from the next few weeks after that. We'll do a follow-up phone call at about a month, just to make sure you're improving the way we would expect. So here, let's, I think I have some pictures here. So here, this is a cartoon just depicting kind of the anatomy here. But these, so let's see if I can put my pointer up. Laser pointer. So this is the parent blood vessel here going down. The cartoon on the left is kind of giving you kind of orientation. But what ends up happening is this is all abnormal. This smudgy gray stuff here is all these abnormal blood vessels. So this is us getting into one of those blood vessels and seeing that smudgy abnormal blood flow that goes to the joint. And that's kind of what we address there. So here's a even better depiction of a selective run. So we get a catheter that's about the size of a long piece of spaghetti. That's what you see here. This is the main parent catheter, which stays in the main blood vessel. And then through that, we put an even smaller catheter. It's even thinner than a piece of angel hair pasta. And we go in there, and you can see here, there's all this blush or this like smudgy area. But that's that neovascularity or new blood vessel formation that's perpetuating that pain cycle. And then we treat this until that blush goes away. Same idea. This is just reinforcing, but here's that smudginess that we were kind of talking about that corresponds to the area of inflammation. I think I have one real case in here. So endpoint. So we kind of talked about we take away these abnormal blood vessels or that neoangiogenesis, which that's what we're seeing here on screen left here. But what we end up doing is we preserve the normal main or parent blood vessels. So we're not taking away all the blood flow, just taking away that abnormal blood flow using those tiny micro beads. So this is a real case. So it's a 57-year-old man with history of right knee pain, status post right hemiarthroplasty. So we already had surgery on his knee, and up to 10% of 10 to 15% of patients after knee replacement can still have persistent pain. Had recurrent effusions after having it drained multiple times and having joint injections, and had pain most pronounced at the outside aspect of his knee, tenderness on exam, which is a good positive predictor that he'll do well with this procedure. So here's a picture here. So this is our base run here. You see all these blood vessels. You see that prosthesis here, which it can get in the field of view, but we have tricks to get around that. We get that tiny little catheter that I said is like the size of an angel hair pasta. And you don't need to be a radiologist to look at these two images here. You see the hypervascularity which is basically perpetuating or causing this pain here of the synovium. And then by the time we're done, that's all gone, but the main normal blood vessel is intact. Same thing on the other side here. You see that hypervascularity here, or that smudginess. And then once we're done there, that's all clean and intact. So discharged home the same day. They were on NSAIDs for a couple days, Celebrex, and it's not uncommon to have like a little patchy rash like this that will go away on its own. It's not uncommon to have some stiffness for a couple days. Most patients have improvement in their pains over the course of the first 2 to 4 weeks, and we assess at a month. Let's see, I think so that's all I have for the presentation. I'm going to go through the questions that you guys may have asked throughout the presentation. I'll be happy to kind of answer any of those. If any other questions come up, I'm happy to answer those as well. Let me see here if I can pull this up. Okay, I have to stop sharing my screen just to answer some of these questions here. Is insurance covering this procedure? So typically insurance does cover this procedure. There may be certain things that you would have to do to demonstrate medical necessity. If you've tried joint injections or other things like that, then sometimes we would have to do that, but it is typically covered by insurance. Do you have a date that you'll be able to do the procedure at the Anderson Clinic in Shirlington? I was told it's coming there at some point. We do not have a date yet for the Shirlington location, but it's going to be the same doc. So it's myself, it's Dr. Chaudhry, Dr. Bagla. So we are performing this 3 days a week, Monday through Wednesday right now, in the temporary office that we have in Falls Church. Someone else asked, is it covered by insurance? And yep, it typically is. If my underlying etiology is my cartilage is worn out and it hurts when I run, is this potentially going to make it so I can run? Yes. So the goal of this is basically to decrease the pain so you can get back to normal activity. Now, this doesn't if the cartilage is completely gone, this doesn't change the structure of your knee, but what it does, just like I said with that synovium, it reduces the inflammation as relates to that injury. So it will reduce the pain and allow you to kind of resume activities that you like doing. What is the average duration of pain relief from this procedure? That's a great question. So we have studies that go all the way out to a year, but this is relatively new procedure been done for the last almost 10 years. We've seen patients this last for 2, 3, 4, 5 years. And patients that it's lasted, that long, we are also open to doing again. Now, if it doesn't work, so the success rate, I would say, if you look through the literature, it's probably around 80 to 90%, somewhere in that range. If you're looking through the literature for clinical success, I would say in our experience, it's closer to that 90 or maybe even higher than that. How do we access this information about this procedure after the presentation? You will get an email after the procedure. After the webinar. And then also a lot of this information is on our website, ircenters.com, which I encourage any and all of you to go to. I think Dr. Chaudhry's probably answering that question directly to that attendee. Can both knees be done in one procedure? Typically, we'll do one at a time. Just because it would necessitate 2 access points, you can't, and we don't want to do that all at once. Just because if you're recovering from one, we want to give you at least one leg that you can kind of function on. But we can do it the next week. It's not something that we have to wait like a year for. What exactly makes the pain go away? What is actually happening when you clear that smudgy area? So what you're basically doing is reducing the inflammation. So steroids work by reducing the inflammation, but it's more of a temporary an indirect cause of reducing that inflammation. We're directly reducing the inflammation by reducing the flow in those abnormal blood vessels. Because essentially what inflammation is increased flow or hypervascularity in a region. So that's kind of what the idea is there. So please describe how exactly you embolize the blood vessels. So basically, we're using those catheters to go. Catheters is just a medical term for a hollow tube. We use those long, thin, hollow tubes to go to these abnormal blood vessels, and then we slow down the blood flow using tiny little plastic micro beads. Or sometimes we even use a medication called imipenem, which is basically a dissolvable. It's an antibiotic essentially, but it's a dissolvable. It's like a salt. It's a dissolvable embolic essentially. So one of the two, either a microplastic or a like salt essentially, but it's an antibiotic. Are you associated with the Anderson Clinic? Yes, we are. So we are. We started this venture, and we're basically the interventional radiologists who work for Anderson Clinic. So we share all our patients. We share the electronic medical records. So if you see one of those docs and they think you're a great candidate for it, it's very easy for them to send you over to us. Can people taking blood thinners with such as Eliquis be treated for this procedure? Those are actually great candidates for this procedure. We typically do like patients to come off the Eliquis for 2 days, but they can oftentimes just resume it that evening or at latest the next day. So it's a good option for me. My doc says my knee is bone on bone. Will this procedure reduce this and how? So it potentially could. So like I mentioned, we use something called a Kellgren-Lawrence grade, and if it's all the way down to 4 severe, it's less likely to have the same degree of impact. But sometimes when someone's explained to you bone on bone, it may not actually be that severe of a grade, and it could be somewhere in between. So it still potentially could benefit from it. So I would encourage, if there's any doubt, just reaching out and seeing if we can review kind of your case directly. We can share the presentation is being recorded and it can be shared. Does it also decrease swelling in the knee? Yes. So when you decrease that increased inflammation, that's going to reduce. So the synovium, like I mentioned, is the lining of the joint. It's what produces the fluid in the knee that can cause swelling when that fluid isn't resorbed at the same rate that it's being produced. So it will reduce the swelling in the knee. Yes. What's your personal success rate? I would say it's over 90%. It's probably technical success rate is probably 99%, and clinical success rate is probably around 90 to 95%. Can the blood flow back into the vessels that were blocked off cause a recurrence? Typically, it won't in the short term because those blood vessels are actually normal. So it takes time to get that neoangiogenesis of the new blood vessels to form. Is the smudginess caused by bleeding in the tissues? No, it's not bleeding onto the tissues, but it's more these new abnormal blood vessels trying to help. I think this means, does embolizing the blood flow lead to tissue death? No, this does not cause tissue necrosis. We talked about that. If you've had an ACL tear in the past, that does not preclude you from this. You'd still be a candidate. Can this procedure be done on thumb arthritis? So that's a great question. So the people who've actually innovated these types of, we call them MSK or musculoskeletal procedures, are in Japan. This doctor named Uji Okano, and they are doing thumb arthritis treatments currently. It hasn't been done in the United States as of yet, but that is something that potentially could be a benefit. Has this pain been applied to lower back issues? Same idea. This also has been done in Japan, but we are not doing that just yet. Medicare typically does cover the procedure. People are asking if they can send their imaging to the doctor to see if they're candidate. Yeah, I would encourage you set up a consult, send your images over, and we're happy to kind of work through that. Someone asked, will this procedure require physical therapy at home or in our office? And is that covered? This procedure itself does not require physical therapy like you would after you go after surgery. Someone recently had a hip replacement. How long should I wait until go for a knee procedure to minimize my overall pain? I mean, that's really kind of up to you. The hip replacement doesn't preclude us in any way. I mean, I wouldn't go the next week or two, but that won't preclude us. Is this procedure essentially an interim or interval procedure before a full knee replacement? It potentially could be, right? So that's the idea. We want to buy time. So this hardware knee replacement, it's like tires on the car. We've come a long way where they work a lot better, but they're sorry, hold on one second. Okay. Yeah, so they work a lot better, but it doesn't. The knee prostheses, they all have a shelf life. So any way we can kind of push those off, the better. So yes, this essentially could be an interim procedure to push back when you have to get your total knee done, or in the setting of patients who've had total knees done and had persistent pain, then that would also be a situation. If you had venous ablation, can you still have this procedure? Yes. So we're in the arterial system, so it's completely separate. Patient has a bone spur on the outer corner of their knee. This So bone spurs basically form as a result of osteoarthritis. Um, and this will help with that pain. I have a question here, and this is what I just got a text from our business partner here. But does Anderson Clinic refer candidates to you? Yes, they can, and they do refer patients to us. So the process basically is you can get a referral from your Anderson Clinic physician, and they will send you over to us, and we will see you, and we'll decide whether or not you'd be an optimal candidate for that. And we've kind of discussed all the pros and cons to the procedure as it pertains to you and your medical history. We'll obviously go over the procedure in more detail. And kind of, we talked about some variations where you're going from the groin to the knee. We'll kind of talk about why we would choose one or the other in your particular instance. So if you talk to your doctor at Anderson Clinic, they can give you a referral to us, and we'll see you in consult. So some of those questions about is my knee bone on bone, all those types of things would be able to kind of sort out in that consult. And like I mentioned earlier, we share a medical record. So I would see all the notes, or we would see all the notes that your orthopedic surgeon would have already put in, all the workups that they already had. Will I be able to discontinue my pain management after this procedure? That's the hope, and that's the goal. As you saw in that study, most patients, more than half the patients, reduced their amount of pain medication that they would have to take. Can this procedure be used on other parts of the body? Yes. So MSK, or musculoskeletal embolization, is done in different parts of the body. Right now, we're doing it for knee, we're doing it for shoulder, we're doing it for hip, and we're also enrolling for a study for plantar fasciitis. But to answer the question, yes, it can. So yeah, so Anderson Clinic is working on building out information on their website as well. So I directed you to our website, but you can go to Anderson Clinic's website as well, and they're eventually going to have all this information as well on their page. This presentation will be available. So okay, a participant said, I had knee replacement in 2022. I still don't have feeling on the outside of my knee. Would this help? This typically only helps with pain. So if you're having numbness or not having a sensation, this won't necessarily help with that. Great question. How long does the procedure itself take? Honestly, this procedure can take anywhere from 20 to 60 minutes on average. And a lot of that has to do with, and I think you could tell with some of those pictures, is that the tortuosity or the twists and turns in the blood vessels. Some people are just born with more twists and turns, and it may take a little bit longer, or you may have to access a few more blood vessels. Any associated risk with catheter insertion, et cetera. Yeah, so any procedure you do. So like I kind of talked about in the beginning of this, is that IR, or interventional radiology, we're trying to always push for doing something that's least invasive with the least amount of side effects or risk. Risk with this procedure, anytime you take something from outside the body to inside the body, there's risk of infection. We use sterile technique throughout the procedure, and we give you antibiotics. So that risk is very small, but it's never going to be zero. And then anytime you're accessing a blood vessel, there's always a chance of bleeding or injury to that blood vessel. But we use image guidance to get in the blood vessel, and then throughout the procedure. And at the end, if we go through a large caliber vessel, we'll use a closure device. So risk is very small, but not zero. And then the last thing that I usually like to tell patients is anytime you're slowing down blood flow in a blood vessel, there's a chance that some of these materials go somewhere where you don't intend. In this procedure, that's very unlikely, but if it were to go anywhere, you could potentially, what has been reported in the literature is that it goes some to the skin. There can be, I mentioned that discoloration, that's normal, but even maybe a small ulcerative wound that would heal on its own. I haven't seen that in my experience, but it is in the literature. Let's see here. So a patient a participant says that their orthopedic doctor, Dr. Fricka, said knee isn't bad enough yet for a complete knee replacement. Is the next step for me to talk to him about this or come see you guys? Yeah, so I would talk to Dr. Fricka and ask them for a referral over to us, and we're happy to see you. Is there an age limit? No, there is no age limit. A few more questions about risk or bad outcomes. We kind of talked about that. If both knees can't be done at the same time, how long is recommended? There's no real time that you need to wait between knees. We just don't like to do them on the same day. I'd say maybe a week or two is usually kind of ideal to allow you to recover from the first. So I've had a cortisone shot in my knee to reduce the inflammation, but it did not give 1 ounce of relief from the pain. So would this translate to this procedure? Would it be reasonable to expect the same sort of outcome, no relief? That's a little bit more of a complex and nuanced question. You could still potentially benefit. I think the best way would be to kind of go through your individual case, and we can do an exam to see how you would do. Can you walk upstairs on the day of the procedure? Yes, you can. We typically will tell you, if you sleep upstairs, just go up the stairs when you go into bed, and don't go up and downstairs the first day, but the second day, that's fine. Talking about working in different joints. What information is there about the possible allergic reactions to plastic beads or intravenous contrast? Yeah, so we have patients know the beads are innate, and we've been using them for decades. That clinical trial that I mentioned that I'm a part of, my partners are a part of, it's investigating those beads, but those beads have been used for decades in other parts of the body without any issues, and they have FDA approved for those. For the contrast, we treat patients who have contrast allergies not infrequently. There's a process of pre-medication that we give, which is basically a steroid that you take orally leading up to the procedure, and then we give IV steroids and Benadryl. Is the procedure indicated with patients with pain after knee replacement? Yes, this can be done in patients after knee replacement. You should get a referral from your orthopedic surgeon. Typical age range. So there's not really an age range because the patients who see us vary in age. We see patients as young as 40 years old, and as old as we had a patient today who's 96. So there's not one age range who necessarily does better or worse. So would you know if a current patient is a good candidate based on their history with the Anderson Clinic, or is a new workup necessary? So the information that we have with the Anderson Clinic is going to be crucial and huge, because that will ensure that you have already gotten adequate workup. But we always do a consult on our patients before going for this procedure. So we would do just that. So we want to personalize this best as we can and make sure we got all our ducks in a row there. Is this procedure for only patients in constant pain versus patients with pain only with activity or on steps? Nope. Patients with activity or on